So fee for service versus fee for value. And the hospital's saying, we do fee for value. We pay our doctors based on the value of what they do. They all say it. But take a look at JAMA. JAMA is a really good journal. And the group that did this research was out of Harvard, not a shabby place in terms of research.
For the latest in health-related information and ways to save your life, check out the newsletter.
And here's what they looked at: physician compensation arrangements and financial performance incentives in U.S. health systems. Public and private payers continue to expand the use of alternative payment systems, aiming to use value-based payment. Hospitals, which hire over half of the primary care doctors in this country, say that we use it. Health systems and their employment of physicians are still growing. Health systems, code word for hospitals. The study question is, do hospitals pay physicians for quality or quantity? In fee-for-service environments, they're rewarded based on quantity. Volume of procedures, not quality or patient outcomes. Isn't that a little bit scary? Objectives and methods. In this study, the authors looked to characterize primary care physicians and specialist compensations arrangements among U.S. health and measure the proportion of total physicians' compensation based on quality versus cost performance. This was a cross-section of mixed methods analysis of in-depth multimodal data, compensation document review, interviews with 40 physician organizations, leaders, and surveys. So what they did was they went to 40 different hospital systems. They interviewed the leaders. They interviewed the doctors. They looked at the compensation documents. They did surveys. And then they analyzed the data from 2019 to September 2020. Here's what they found. Doctors were being paid for referrals and procedures, RBRVU. Remember I said that? Volume-based compensation was the most common base compensation. For primary care docs, 84%, and for specialists, 93%. While quality and cost performance incentives were common, the percentage of compensation based on quality was below 10%. Your local hospital hires your doctors. This happens with over half of the doctors in this country. And they say we have a quality-based system, and no, it's not. Quality is less than 10%. So you're grist for the mill. Increasing the volume of services was the most commonly cited action for physicians to increase compensation. So the conclusion was, despite receiving value-based reimbursement incentives from payers, so the payers are out there like Medicare and Humana and others that say, we pay for quality. And the hospitals say, yep, that's what we do too. We've got programs set up there. The compensation of these health systems, primary care docs and specialists was dominated by volume-based incentives designed to maximize not patient health, not population health, hospital systems revenue. And associated risk is iatrogenic disease. If that weren't bad enough, you got to remember, as I've said already, every time you do a procedure to a patient, like a stent, you got to remember, we can cause problems like bleeding in the groin where we stuck that giant needle, which that patient would not have had we not done that procedure. That's what iatrogenic problems means. Iatrogenic disease is a result of therapeutic procedures. It's induced in a patient by the treatment of the physician. Let's take another twist and look at, this is a negative outcome on doctors and the providers, not a negative outcome for patients. So if doctors are still hung up in this fee-for-service mentality, this village blacksmith under the old chestnut tree, if they're getting paid 30% less for every nail they make, so what do? Well, they try to figure out how to make nails faster. Does that sort of ring a bell with you and your doctor? 7 minutes, they rush in, pat you on the back, hey, how's Uncle John? Let me look for a script I can write for you, because if I write a script, then I can get paid at fee for service. And we really don't want to dig deep in terms of metabolism and your understanding of things like diabetes, insulin resistance, because that takes time and it doesn't really get paid in the fee-for-service environment. So guess what? It's bad for you, but it's also bad for your doctor. Well, what do you think's causing physician burnout? This is exactly what's causing it. We do have a great medical manpower team, very, very well trained, but unfortunately, once they get out into the quote real world, which is fee-for-service driven, they have very difficult time actually doing what they were trained to do. They get on that fee-for-service service treadmill. The authors of this meta-analysis, this was a meta-analysis, so study of multiple studies. They looked for the relationship between burnout and patient safety. And this included 21 studies from different countries along the U.S. High levels of burnout were more common among physicians and nurses associated with high workload, long journeys, ineffective interpersonal relationships, and a relationship between burnout and patient safety actions with a probability of superiority of 66%. I'm not going to go down the technical epidemiological bunny hole of probability of superiority in any of that. You understand it. If your doc is burnout, if they're doing too many procedures, if they're not communicating effectively with you, they're likely to do something. And that's the biggest problem with healthcare in the United States today. That's why, despite having such a great manpower resource team out there, we've abused it. The doctors are doing poorly, and when the doctors are doing poorly, they're hurting you. You know, I'm staying with my mom right now, and she asked me yesterday, what's the topic? And I told her, she said, that's kind of inflammatory, isn't it? And I said, well, sometimes the truth is inflammatory.